I give him a hard time, but he has to give me that instruction so that we are in sync. Welcome to the Community Paramedicine Insights Forum for March 2019, brought to you by the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, the Center for Leadership, Innovation, and Research in EMS, and a special thank you to Mayo Health for supporting the back end of this show and for having done that for several years. Couldn't do it without you. Thank you very much. And also to Gary Wingrove, my partner in crime, for this series, for helping me with everything. There was a note, there's some folks having a little bit of trouble logging in, and there's a note on the participant feedback chat in the lower left-hand corner. For this month, we have a two-part program. I'm going to start with an update of a survey that we've done with state EMS offices in the last few months. And it is a survey on community paramedicine, mobile integrated healthcare, and current status. That survey was actually first done in 2014 and 15, and so we did a reprise of that beginning at the very end of 18 and into 19, and so far we have 40 states that have responded, and between the chair of NSEMSO's Community Paramedicine Mobile Integrated Healthcare Committee, Jim Deteen from Montana, and myself, we are trying to squeeze out the last few. But we have some very interesting results, and I think that at this point, they are. I think that they're worth talking about. We'll be back when we have hopefully 50, and we'll give a highlighting of any differences that we've found at that point. So again, we started this in 2014 and 15 and did a reprise of it at the end of 18 and into this year. The first slide that you'll see is a very interesting one based on activity for CP development, CP program development in states. In 2015, the 54% of the states reported either some, that means 1, 2, 3, or widespread CP being provided. And at that point, somewhere around 8% or 10% of states had no CP activity. In 2018 and 19, nobody reported no activity. And in fact, we have 66% of the states reporting some activity, another 13% reporting widespread activity. So we're well up there into 80% for activity currently, and then another 15% of states have planned services at the local level, which means it's gone far enough at the local level that they are actually planning services, which brings us up into the 90 percentile for services that are present or being planned in the near future, which is quite the increase from a few years ago. Staff involvement has also increased. In 2014-15, half of the states had some staff involved in CP MIH planning. Now that is 80% of the states have somebody working on CP. We're going to flesh this out in the future with finding out exactly who's doing what, whether it's a part-time job, as it is in some places, one hat worn of many, whether it's a dedicated position, how it's funded, or whether there are multiple positions. And we're going to hear most of the above with our three speakers later on. Do you expect to have regulations governing any aspect of CPMIH? Well, it was around 20% in 2014 or 2015, 14 to 15, and up to 50% planning within the next 2 years to have some regulations governing some aspect of CPMIH. How do you plan to permit community paramedicine personnel to practice in the future? The vast majority of services are either going to, and this is 60%, are anticipated to practice by virtue of changes in the regulations allowing somebody at a certain license level to practice community paramedicine as well, as long as there's a proviso for that, they have appropriate training, they're within the scope of practice, that sort of thing. No extra endorsements, no extra anythings on their license or attached to their license. It's just a part of their license if they have the appropriate training. And then another, so that's 40% of that 60%. Another 20% or so will have actual endorsement on that license. Few at this point are anticipating a separate licensing level or licensing category. How do you permit provider agencies to provide CPMIH? Again, very similar results. They're not really expected, for the most part, to have any special action. There will be some endorsements on 30% of the cases on their current license. At 45%, they're going to have neither a specific license or certification for CP, and in 25% of the cases, they will have a separate license or certification category for CP, and then they just may be licensed for multiple things, which is a more common thing to do with agencies than it is with personnel. You have regulations with a scope beyond your state's current EMS scope of practice definitions. We only had 3 states in 2015 answer positively about that. At that point, when this was evolving, community paramedicine was pretty well understood that we were not intending to increase scope of practice. We were intending to change the locale of practice, and that basically was it, or the setting of the practice. In 2019, however, we have seen something of an increase in that, something over 20% of the states said yes, but with a comment. And the gist of those comments were if there were specific local practices permitted by local physicians, because we are not a scope of practice state necessarily, or if we are a scope of practice state, if there are the ability within our state to have local variances from scope of practice, then we've, in some cases for CP, have activated those. And so it's not uncommon that a state that allows blood drawing, for instance, for blood glucose or what have you, to allow blood drawing for monitoring in other devices, INRs or whatever. And in some cases, that goes even further to point of care diagnostic draws. And in some cases, it's also a matter of how people define their scopes of practice from state to state. So some have broader definitions than others, and some feel it's necessary to very narrowly define some of those scopes, and they considered that a change from scope of practice. Our agency that provides CPMI services required to have medical directors specifically for that activity. We've gone from 52% in 2015 to 62% today. And I don't have an explanation for that. We we're a bit concerned that that question was originally being misread, and we think that the explanation this time was adequate. So we hope that that's relatively accurate. That in fact, the state EMS offices, when they say that, are requiring that there is a physician or a medical director specifically for CP-type services. Are CPMIH services required to do community health needs assessments before commencing service or use an existing assessment? In 2015, we saw that 30% said yes. In 2019, we see that just about the same amount said yes. And so we're not sure that reflects, I think, that we have a majority of the CP services out there that are coming up from the local level. They're being formulated locally based on needs that people have expressed locally, and hopefully those needs that have been expressed are actually turning into needs that need to be fulfilled, and will create room for a long-term program. We'll see. But that has not changed. Are services required to demonstrate any integration with other community health services? Only 40% said yes in 2015, and about 40% said yes in 2019. It's a little bit more. And that is something that goes along with the concern about stepping on toes in terms of other professions, disciplines, et cetera. And don't really have an explanation for any more of that, because I know from experience going around the country and looking at different programs, folks are managing those issues of territorial turf well on their own, given their own issues that they need to deal with, and having necessarily something dictated by the state in that regard may not be helpful. We've established state-level benchmarks or indicators against which to measure the relative success of CPMIH services. In 2015, we saw 14%, 15% said yes. Today, we see exactly the same. I think that this may be concerning, but and I say that mainly because we need to see out of the practices themselves, the areas that are doing the programs that are doing CP, a lot more data than we're seeing now. We're starting to see a lot, but we definitely are in need of the evolution of benchmarks, the evolution of, we have performance measures that have been developed on the national level for this, and we just need to see them employed. If you adopted, did you plan to adopt an evaluation plan at the state level? Back in 2015, it was about 30%, and today it's 32%. So again, I'm not sure if there's a concern that the state needs to do some kind of evaluation plan for this new specialty, however it is called in each state. But it certainly, I think, identifies an area that ought to be addressed so that we know what is a reasonable expectation of state EMS offices with regard to community paramedicine and mobile integrated healthcare. Do CPMIH provider agencies use the state EMS data collection system or CPMIH patient record entry? It was all over the place in 2015. It's all over the place in 2019, and basically goes to the issue of finding a patient's electronic health record that works with community paramedicine as well as with regular EMS paramedicine, and that can serve all of the consumers of ePCRs or other EMS patient records, and there are many of them now. We have not only state EMS systems with NEMSIS that are consumers of this data, and our own agencies that are consumers of data. Presumably, EMS agencies and state EMS offices have learned, for the most part, to live well together with a NEMSIS-generated system. But then we have new medical directors in the form of community paramedic medical directors that may want slightly different information. We have health information exchanges that may want certain information, and we want certain information from them in real time too, more and more in the future. And then we have Cerner and Epic and other hospital EHR systems and doctor's office systems. And that's a large issue. It's a contemporary issue now. There are a lot of folks that are out there on many fronts addressing this, and the solution has got to be at some point in the back end of these systems to allow a paramedic to enter the information from their patient encounter once and have those consumers of that data pull out what it is that their system needs from that and take what they need from it, so that a medic isn't doing 3 run records for a certain call, which is in the case of at least some services I'm aware of. Talking about financing, I think we have reached something of a tipping point at this point, particularly with the recent announcement of the ET3 program by CMS, the new Centers for Medicaid and Medicare Innovation pilot program for reimbursement for treat and no transport and treat and alternative destination transport, and some triage service reimbursement. We now have CMS on board with that, as we have seen Anthem Blue Cross Blue Shield come on board, and we're seeing United and Aetna and others going from their pilot projects perhaps to broader programming, and the examples are even broader than that. So these were the questions in 2015 we asked. Is there a strategy being developed in your state for CPMIH reimbursement? And at that point, that general question was yes on 36% of the cases. Today, the question asked a little bit differently, but essentially the same. 48% were saying yes, we're developing strategies. And most of them gave the examples that one would expect in terms of working with various third-party providers in their states, Medicaid in particular, about reimbursing CP. Is there specifically any activity to use Medicaid to reimburse? In 2015, we saw about 45%. 2019, we're seeing 61%. That's an increase there. We know of a half a dozen states now that are actively doing that. Are third-party payers involved in development of CPMIH reimbursement strategies? 32% in 2015, 51% in 2019. Are hospitals and health systems involved in development of CPMIH reimbursement strategies? They were, in 2015, we were struck by the number of states that said yes. We had 64% of the folks saying yes. There were some of that kind of activity going. In 2019, it's a little bit more, but it's about the same, 68%. And that's good. It was just very interesting that is the area where we've seen the most interest, and it has it's still there. And I guess that would be the end of that. So that's the information that we have. Gary, you can unmute and just see if there are questions or comments.
The conference has been unmuted.
So We do expect to try and get a few more states into this and see if that changes anything. I'm not really sure that it's going to. I think the results are not only interesting, but I think that they reflect not only the widespread presence of community paramedicine, mobile integrated healthcare, but the seriousness with which state EMS offices are taking the advent of this new form of provision of paramedicine and actually investing in it and starting to oversee and help plan and enable it. Any questions?
Hey, Kevin, it's Jean Marie in Colorado.
Yep.
I was just curious if this was, good morning, good afternoon, I guess. It's been a busy day. I was just curious if this was what you expected to see or had hoped to see from states. It looks like there's good momentum on many fronts, or if you were hopeful for a little more.
No, actually, I think that seeing 90+% of the states that actually have CP services, or, well, I'll say 80+% that have CP services, 90+% that expect to have it, have some imminent services as well. I couldn't be happier. I mean, I think it's definitely where we should be, and I didn't have an idea. I know that the NAMT survey has shown an increase in the number of communities having it, but that obviously doesn't equate to its presence in states on a wholesale basis. So I personally, I think it's good, and I think that the financial reports here as well in terms of those supporting CP services is kind of going hand in hand and will probably increase greatly with this new turn at CMS, and also the recent happenings with Anthem Blue Cross and other things that folks like Matt Zavatsky have made us aware of around the country in terms of particularly health system and ACO activity. Other questions?
Kevin, Carrie Cadle.
Yeah.
Kevin, what do you see is the primary sustainability model being used? Is there one identified as the a model that's actually promoting sustainability?
I think it's too early. My opinion is that it's too early to cast one model out there as the model. I think that we all have a sense that the future lies in population health-based, value-based models. That is, we become a part of a capitated reimbursement process that's of value to a whole health system, and that's how we survive. I don't think folks really have a long-term expectation that any kind of fee-for-service type of reimbursement model is going to be in the long run, because it's certainly not in healthcare in general. So I think what we're going to end up seeing is going from some form. Let me just step back. I think that early CP services that are starting, what we've seen are two ways that they're starting. One, somebody makes a decision that this is the right thing to do in our community. We have some health needs, and we're just going to do it because we have some excess capacity, perhaps within our ranks, that we could actually apply to this. Or we have a grant, or we could get grants, or other sources of funding, at least on a transitional basis, to fund it and try it out. So I think that's probably, it's either the excess capacity argument that it's the right thing to do, or the ability to get grants is where people are starting. And then the problem with that has been over the last few years is that the actual sustainability has not proven out of the reimbursement models we've had nationally. And so we've had programs that have dropped because they didn't see, the golden goose laying in the end, if that was their interest. So I think that ultimately we're going to be most successful in the future in those incapitated types of programs, getting with ACOs, getting with health systems, getting to be a part of an overall approach to the community's health care, and capturing back some of the savings that we're making for that system ultimately. I think to get there, we've got to do grants. I think we've got to take advantage of Anthem Blue Cross if you can do that, if you can manage to, you're one of those 14 states and can sign a contract with them, that's an opportunity, or United or Aetna or anybody else that's doing pilots. I think that's where you want to start talking as soon as you can with folks, third parties in your state, about things that may be of mutual interest. Because I see most of these programs are starting with very sort of narrow, targeted patient groups that the third parties are interested in having community paramedicine try and address. So it's sort of piecemeal targeting, some fee for service, some capitated programs, and then moving in the future to capitated and population health. And I'd be glad to have a discussion about that. There may be some disagreement out there.
Thank you. Appreciate that.
AJ Ferreira asked, will there be updated CPT coding to reflect community paramedicine visits? I have to admit that technicality is beyond my ken. I know that the codings that for treat and no transport and alternate destination, there are codes that are going to be, I think they're going to be flexed to accommodate that, if they don't already. But that certainly is going to have to happen. Now, if there's anybody on the call that knows more than I do about that, I know Matt Sabatsky can answer that question. Dan Swayze, you're on. Do you know that?
I don't know whether it'll be a set of no codes or they'll simply allow EMS providers to use existing HCPCS codes for things that we traditionally have not been able to bill for, or use modifiers on our existing codes to reflect some of the new opportunities that are out there. It'll probably be payer dependent until some consensus evolves.
Thank you for letting me hit on you like that, but I knew you'd come through.
I hope that helped.
It did. Any other questions? Okay. Well, that's what we know now. Let's go on and talk about what the future holds for us. In 2009, as far as I know, in 2009, Maine was the first state to have to actually employ somebody in a CP coordinator role. And since then, I've known states to have coordinators come and go as a job that may be among many other jobs or hats that they wear. But now we're starting to see some dedicated effort among states to enable community paramedicine, mobile integrated healthcare in their areas. And I thought it would be interesting if we could get 3 of the newest that I'm aware of CP coordinators to talk with us about where they came from, where their program came from, and where they see it going. And I'm really pleased today to have Carrie Cadle from Alaska, Lydia McCrary from Georgia, and Amy Allison from Montana. And they are all 3 full-time statewide CP coordinators in their states. This is just fascinating. So let me start. I'm going to ask the same question to the 3 of you.
Hey, Kevin. Should I mute?
Yeah, I'm sorry. You want to mute?
And then,
yeah, go ahead. Sure, go ahead.
Okay, so we're going to mute all of your lines and then unmute these 3 folks, and then we'll do question and answers afterward like we did with Kevin. 1 minute.
The conference has been muted.
Kevin, you should be unmuted.
Hi there.
Amy, could you check your check-in?
Yep, I'm good.
Okay. Lydia?
I'm here.
Okay. And Terry? Terry, can you check to see if you're unmuted? Kevin, I'll try to track him down. He might get disconnected from another phone. You can go ahead.
Okay, sure. Well, let me start with hopefully the warmest of the three states at this point. Although these days it's tough to tell. Lydia McCrary, Georgia EMS. Welcome to the CPIF program.
Thank you.
Good to have you. Tell me a little bit about your history in EMS.
Well, I've been in EMS since 2001 and became a paramedic in 2005. I've had experience working in urgent care settings along with field EMS in Savannah, Georgia. So I've gotten to experience various different aspects of the EMS field, from provider to supervisor. And I got the opportunity back in 2016 to become the program director for the mobile integrated healthcare effort in Savannah. And once the state opened up an opportunity at the state level to join their program for their efforts for the state, I was able to join in with the state of Georgia along with 9 others to be able to implement and assist those trying to start programs throughout the state of Georgia.
Wow, that's great. What did you do in urgent care?
At urgent care, I was a paramedic. So there in the state of Florida, I was actually in the state of Florida when I was in the urgent care setting, but they allowed us to interact as a provider along with assist the physician. So we got a lot of experience, a lot of hands-on experience that I necessarily didn't get the opportunity to do those skills in the field. So it was very valuable to learn to work not only with the physicians and the pediatricians at that level, but also the hospital providers and insurance coding and things like that. It was definitely an experience we wouldn't get to normally do in the EMS field.
That's fascinating. I think that's one of the first times I've heard of community paramedics being used in an urgent care setting like that. I think that's really great, especially having the opportunity to actually practice.
Yes, it was a great experience.
Cool. So tell me, you've got 9 of you in the Georgia EMS office. Tell me about where, how did Keith Wages come up with this idea to do this? He's the state EMS director in Georgia. How did he come up with this idea to do this? And so where did the impetus come from? Where did the funding come from? And is it 9 full-time people in community paramedicine, or do you have a multitude of other hats?
Well, right now it is, we are slotted for actually 10 of us. And right now we are at 7 who are who've been brought on with the state and who are actively participating right now. So there's, for every region that the state's divided into, they've appointed a community paramedicine. And this was a legislative mandate, so all of our funding comes from that budget. And right now, our focus is solely on mobile integrated healthcare. And while there are other needs in the area, if they need them, we can be used as a resource. However, our focus is on helping programs, identifying community needs assessments in their area, sitting down with them. Some of the EMS agencies just want somebody to come in and maybe go to that meeting with them with a hospital, or other partnerships within the community. And we can assist them anywhere from, just simple sitting down in a meeting with them through training the community paramedics, all the way to going to the insurance providers in the state of Georgia and seeing what reimbursement paths that we can maybe help for some sustainability.
That's great. Are your other 7 colleagues now all coming from a community paramedicine background of some sort?
No, actually, we are really lucky in that when they were doing the hiring process, they picked us all from various fields and different experiences. So that's actually given us the opportunity to reach out into different areas that maybe some of us wouldn't have the experience. So we have somebody who's in emergency preparedness. We have somebody who specializes in the technology aspect of it. There's somebody who's spent most of their career in EMS education. And so they just decided that it would be best if we could try and take all these different backgrounds and join together so that we could be more useful to the state as a whole.
That's very interesting. So, but in any region, if a service is looking to get into community paramedicine, mobile integrated healthcare, and go and have that meeting with the hospital, you're all capable of being conversant in that and being comfortable in doing that.
Absolutely. Yeah, it's wonderful. And we have the opportunity that, if there's an area that maybe, a certain program, they need an expertise that I don't have that experience in, I'm able to reach out to the other region that could come in and backfill that so that we can really make some programs that are sustainable, and that's our goal.
Excellent. So what are you're heading up this program for the most part, or at least Keith said that you're the point person for the CP program. What are your dreams about it? Where do you see this going? Where are you now?
Where are we now? Right now, we're a lot further than we were back in 2016. I could tell you that there was it was a lot harder approach going to EMS directors about community paramedicine, and I'm really excited to see that we have a window of opportunity with Medicaid here in our state that is reimbursing for treat and no transport. They're also reimbursing for alternate destination, and we're hoping to find out soon if they're going to pass for reimbursing for community paramedicine. And I really see that with a solid reimbursement model behind it, that we can start getting some of the EMS directors on board with implementing programs in their area. And I will say that it's not the identification of the need. The need is there. It's being able to fund the program has been our biggest hurdle. So my goal for the future is if we can find some real, solid reimbursement models that we can offer to these directors to have something to sustain their programs, I think that we'll see really them start widespread across the state.
That's great. Do you have third parties there that are, other than Medicaid, that are coming to the table?
Actually, recently, we have had some of our insurance companies who've come to the table and are opening up discussions on possible reimbursement at the state level here in Georgia to start pilot programs, or even just to go ahead and say, we're going to fund this, let us know. And we're really excited to see that I think really the ET3 model coming out has prompted a lot of the insurance companies to want to reimburse for the alternate destination, and really has opened up their eyes into the benefit of the community paramedicine model, and even to the point that they want to provide that cost sharing on top of the fee-for-service as well.
That's very neat. Are the third parties identifying any particular areas that they're interested in participating in, like reducing 30-day recidivism for discharges for certain conditions? Or
So the insurance company I met with earlier this week was discussing their interest, honestly, just in chronic care. And they did not have a deadline, which I was surprised. Previously, you know, discussions were preventing that 30-day readmission. And they're more interested in just the chronic disease management, especially in the rural setting where they don't necessarily have the physicians who are available to provide that care. And I was very surprised at their response that they didn't have that 30-day mark. They actually were willing to provide that ongoing care beyond 30, 60, 90 days. They just wanted to make that as an option for their customers.
Great. Okay. Thank you, Lydia. I really appreciate that. Let me move on. Let's go to Amy Allison. Amy, I've had the pleasure of meeting you. I know you've been a part of a very successful CP program in Montana. And tell me a little bit more about where you came from personally in your EMS career and how you got into where you're at. I think I have a sneaking suspicion since I had the chance to be there at one point. And let's focus on that for a second.
Okay. Again, I'm Amy Allison. I've been a Montana native most of my life, in EMS for over 20 years. I am a critical care paramedic and also a CPC medic as of 2015. And more recently was the director of a full EMS service for about 10 years. And it was there that most of the staff would come in talking about, well, if we could just do this for this patient and they could stay home. And many of those kinds of stories, including that I have a medically vulnerable child at home, led us to start looking into programs such as these. So we were the leader of the first Montana Integrated Mobile Health Program, where I was a director for. We serviced the Blackfeet Reservation in Glacier County, which was about 3,000 square miles and 13,000 approximately in population. It became a really valuable and great program. That is where my passion for community paramedicine really sunk in, and knowing how great it was and that I wanted to see it implemented across Montana and expand the role for the providers of Montana. The stars aligned then. It was just a good time for me to transition over to the state level and work with Jim and Sherry and see what we could do to start helping other agencies implement it and just see where it would go. So that was kind of the start of our journey as far as our partnership to see what we could do for Montana. So after weeks of HR training and all the fun stuff, we finally hit the ground running. And so a little bit, do you want me to just keep going on a little bit about where we're at in Montana now?
Absolutely, yeah. Tell us, where the CP is
Okay.
at and what your dreams are for its future.
All right. So my position came about just through the EMS department there, working with the diabetes and cardiovascular health department internally. They had a HRSA grant and had a little bit of extra funding within that grant to create my position for 5 years. So I'm thankful to be there, getting this initiated. And right now we also have a bill in legislation. It's our SB 38 that will establish the provider status for this program. It doesn't change any of the reimbursement system behind it. It's just creating the endorsement for the provider. It passed the Senate floor and is now in the House, and so we're just waiting and following impatiently, but our glass is half full to see that go through. Secondly is part of the grant that also hired my position, also is helping us to partially fund 6 pilot sites throughout Montana. With that pilot site, we hope that that will provide the data that we're going to need for the reimbursement to occur. So So that would be our end goal. Within those 6 pilot sites, we hope to get a huge variety because Montana is so large. So we would like to see tribal and hospital-based, non-hospital-based. So we want to get a good variety in those 6 to see what this can really look like for Montana. The pilot site will run, each of them will run for a 2-year period, and it will be done through an application process. So we'll have a committee set up to select those 6 sites, which will be going out very soon. We have our medical director meeting Wednesday, and after that meeting is when we intend on releasing those to the agencies. So we just want to make sure the medical director is all completely understood before one last time. So after they're selected in the first few months is we're providing the training, and we'll make sure that they do their community health needs assessments and that they've met all the requirements that we've found anyways throughout the different states that would best identify the needs for each provider. And then we'll just study that as well and make sure that they feel that they got everything they need just to see where we're at. We're hoping, and it's pushing it a little bit, but we're hoping that their programs will begin in July. And I feel confident because most agencies I've talked to are already planning a program and really want to start doing this. So with or without us, I think they're just going to start leaping in Montana. So that gave us an advantage as well, is that they're doing their planning right now and going out to the community and educating. So we'll make sure that they're on track and just provide some of that guidance. With that, we've set up image trend at the state level for the community paramedicine for us to be able to pull the data for us to review. We have internal epidemiologists where we have some of our preset data to be able to provide as we go along. That was when we did our program for the mobile health. We did get data, but we didn't do preset data, and that was a lesson learned, was to just start with preset, not hoping to identify out of all of the material you get later. So that will be done for us to hopefully make that a little bit easier. And Jim had developed this wonderful strategic plan for Montana to follow, so we've followed that all along. And we set up work groups in different fields. So we have medical director work groups, and that's to make sure for patient review, to make sure that we have universal paperwork so we're not getting confused where we're at. We have insurance work groups so that we can make sure that we're defining what they need in our data to see a reimbursement model when we're completed at the end of the 2 years. So that would be our goal outcome. And if those 6 sites were implemented and doing very well, after 2 years, I still have 3 years on my employment through that grant to still be available for other agencies to assist them to implement the program if it's something they would want to do. So I would still be available to that. Other little tidbits is that after the HRSA grant and that funding, after hiring me, we felt that maybe we wanted a little bit more funding to help the 6 sites to make sure they're sustainable for that 2-year time frame. So we did go out and we got a few more grants and some sponsorships. So now hopefully we're sitting at about where we can give each site about $50,000, and I feel pretty comfortable that we can have some successful outcomes with that. And that's where we're at.
That's great. That's super. Thank you very much. I know Jim McKean, the state EMS director in Montana, has had some really good success in the last year. It's the way these things tend to go. They go nowhere for so long, and then suddenly, thanks to hard work and intelligently placed work, success happens, and it's really happened in spades there. How did you pick 6? Is it because of regions? Is it because of what you thought the programs you thought you could fill, or how did you come up with that number?
You know, there's no logic really behind that. It just ended up being that when they did the grant for the diabetes and the cardiovascular, they're like, well, we could just try, 6 sites. So we said, okay.
Okay, well, that's an honest answer.
We were going to turn one down.
do you think you're going to get 6 interested?
Oh, yeah. We've had multiple calls, throughout the week saying, hey, just letting you know we're interested. So anybody that's called in, of course, we said start doing your homework, start educating your community. And I've also helped others where they're pretty advanced in their planning. So, yeah, I think actually our application process is going to be very full.
Great. Well, that sounds wonderful. You mentioned training for your site. What kind of training are you talking about?
We started looking into the college ones. I personally took the one at Hennepin and loved it. But we also, of course, just being a state, needed to see what was available locally. So we started working with the school system, and they have a community health worker program that's already existent, where these folks can take this class and go out and work, and there's codes for billing already for them. But we ended up doing a crossover, like a crosswalk, to see what was needed to meet the guidelines of being a community health paramedic from what we could find in any of the lingo out there. And they developed a program for us, so these guys will be taught online, and then again we'll evaluate it to see if it's meeting the needs for our Montana providers.
Okay, very cool. There's been a lot of discussion about how we fit community health workers and community paramedics together, and whether one can learn from the other or serve side by side or be the same person. So that'll be a really interesting thing to keep an eye on. Let's move on to, I'm sorry. Didn't mean to step on you, Amy.
No, I just said thank you. Absolutely.
Okay. Let's move on to Alaska. Carrie Cadle, good afternoon. Thanks for joining us. Are you there? We're not hearing you. We're not hearing you very well at all.
Hello, can you hear me?
Now we can hear you. That's great.
Okay, good.
All right, so let's start off again with the same 3 questions, and you've heard them 3 times, and I suspect that you can go right in and start focusing on yourself, and then go to where the CP program came from, and then your dreams and hopes for it.
My dreams and hopes. Sky's the limit. My name's Carrie Cadle. I'm a new community, the integrated community health programs director for the state of Alaska. My background comes from fire and EMS. I have been working as a deputy chief in charge of EMS operations for a rural department for 20 years, and then I've also been a fire chief in Alaska. And if you take Alaska, its population is scarce, its landmass is large. It definitely has distance and a sense of rural community to it. My background started in college, taking a course for ski patrol, for the National Ski Patrol, and I started off doing that. And as I was going to college, it was much cheaper to ski if you were on the helping end, helping members of the ski community while trying to buy ski gear and ski tickets as a university student. And I spent most of my life in Alaska, and right now I'm working in Anchorage. The capital for Alaska is Juneau, where half of the office for the health, for the EMS office is in Juneau, Alaska, which is about a 2.5-hour jet flight on the Panhandle. and in southeast Alaska, and the other half is in Anchorage, where just recently, and my position came available through the leadership of the section of Rural and Community Health Systems and part of the Health and Emergency Response Group, HSS, and the leadership within the state saw the need for community health paramedicine and somebody to be able to take it forward and help develop programs. Paramedics are under the state medical board, and EMTs in the state of Alaska, we have EMT 1, 2, and 3, and a 3 being a not quite parallel, but kind of a critical cardiac treatment technician group that is under the Health and Human Social Services, while the paramedics are under the direction of the medical board, state medical board. So part of the goals of this program right now is to first kind of look out and look at the different communities and complete an assessment to see where these gaps lie, and as gaps are identified, to try to help organizations such as like the Indian Health Services or the Alaska Health Aid Program, as well as EMTs, and try to develop a program where they can do a integrated community health program. So it wouldn't necessarily have to have a paramedic involved, but it would still be a community health aid health program that has the same as a community paramedic in practice, in theory. But this program started because Anchorage had, with the gentleman starting a community outreach and referral and education, a core team, and that was based on a high utilizers identified within Anchorage that were creating a system that had a lot of dedication to a small group of individuals that were identified as high utilizers, and trying to see how can we best fit their health needs. And it was identifying housing issues, medication issues, resources that took multiple from mental health, multiple people within the community to better fit a group of high utilizers' needs, so they weren't always utilizing an already tasked system and already tasked hospitals, where they could be better served just by resourcing resources that would be more fit to their needs and be able to actually help these individuals better. So that's where we're moving. My hopes and dreams for this program is, one is kind of like Amy was just saying, developing a system where we can have legislation, so we can also have legislation for the community paramedicine, community health aides. Another aspect of hopes and dreams would be in complete integration or critical access hospitals or collaborating with EMS systems, and then also having the potential for things such as like telemedicine to be able to integrate with that. But first off is identifying the gaps in each and rural communities, so we're better fitting a program that works for them, that is successful. So that's where I am at.
That's great. So of course, I'm interested with your thought about integration of existing services and community paramedicine type services. Of course, Alaska was the model out of which a lot of community paramedicine activity started back in the 90s with the community health aid programs that you have. Is your integration, I sort of got the flavor that your integration is taking existing community health aid services, which are not necessarily EMS or EMT. They obviously, community health aides, especially in smaller villages, are expected to draw upon their resources to do some emergency stuff, but they're mostly chronic focused. Is that what you're talking about, trying to coordinate?
Absolutely. The coordination and collaboration here's an example. So Indian Health Services, like you had mentioned, with the community health aid programs, deals with the Indian Health, under the umbrella of the Indian Health Services. We have a level of pre-hospital, or kind of a pre-hospital emergency trauma technician for the state of Alaska, or an EMR program, or EMT. They're trained at that level, but they also have significant clinical experience for mental health. They can do suturing and a lot of clinical aspect training for these individuals. Currently, this group is only allowed to practice in rural village communities. The other day, having a meeting with a leadership in Anchorage with Alaska Native Tribal Health Consortium, they have a group of people that have removed themselves from villages. They're living in a more in Anchorage, but they're unable to work because of that. They're with that understanding, with that training, they can only work in rural Indian areas. So what we would try to do is, we're in the process trying to rewrite a job description for them that isn't clinical based, but with that base training that they have, trying to write a new job description for them so we can get like a mutual aid agreement with the municipality of Anchorage and the Anchorage Fire Department, where these people could be hired, supported through the Alaska Native Health Tribal Consortium, and be able to work in Anchorage under a core program. So that kind of collaboration where their skill set would still be useful, and they would also be serving a community, like I said, the kind of like high utilizers. There would be an aspect under core, because there's somebody who can be a just a coordinator of care, and that would be a perfect aspect or a perfect example of coordination, like you were mentioning.
Interesting. Gary, I think it's time to take the mutes off and see if we have questions from the audience.
Okay, here we go.
The conference has been unmuted.
Okay, so everybody has the opportunity to just speak up with a question. So let's just have at and see if we have any out there.
A question I had for Amy.
Oh, please go ahead.
Hi, Amy. This is Carrie Cadle. A question I had for you. You had mentioned sponsorships.
Yes.
And can you give some examples or describe what you mean by that? I'll go on mute.
Sure. So just because I was trying to make it to the 50,000 per site, I wanted to start getting creative and keeping some of the funds we had. So, for example, we're working with Image Trend right now to sponsor the 6 pilot sites in return, I wouldn't be paying them the full amount that was on the quote. And so that money would stay to the pilot site. So we started looking at things like that. You can be invited to do a grant through Verizon, through your local Verizon, and so we've started doing that for their jetpacks and their tablets, just ways to not spend the money we have to keep it to the sites for specific needs that they have. And I've reached out to insurance companies as far as being a sponsor to the 6 pilot sites, hoping to get funds and also to get their interest to watch the pilot sites for reimbursement at the end of it. So that's just kind of what I did, is set up a little sponsor package. And so in return, the logos would be on all of our materials, or whenever I go out and speak at a conference, of course, they would be noted on all of my material. And so it's just ways like that to help promote them and support our program.
Awesome. Thank you.
Yes.
I would note that I think that's great, that there's also the opportunity as FirstNet evolves for utilizing FirstNet services, where today you have AT&T or soon will have AT&T services. And I know in our rural communities that they're there in some places, not in others, but they're coming soon. So that's something else to keep an eye on in terms of affordable data communication services. That is public safety's own dedicated broadband network. Let me just ask the three of you, do you have fairly well ingrained home health care in your state? And if so, has there been any evidence of folks feeling threatened in that area by community paramedicine?
This is Amy. You know, it just is dependent. We have such a large state of miles, and so in our larger towns, of course, the home health is pretty prominent. You reach out into really rural areas, and there just really isn't any resources. So where we first started our program, there wasn't any at all. But what we did do was go to the larger areas and did some of our clinical time with them. And they were so excited that they would be able to work with us as an extension in our area for the home health. So we thought we were going to have some of the turf issues, and we actually did not have any.
Thanks. Lydia?
You know, I will say in the state of Georgia, we're lucky that there are a lot of home health services available. However, when we get to some of our rural communities, those options are not always available. And we did meet some resistance, but I have found that in each community that we go into, the first thing that we encourage everybody to do is have that stakeholder meeting. And like Amy said, allowing for the clinical to take place in some of those settings really bridges that partnership from the beginning to show that it's more of a partnership than somebody coming in to take over anybody's role in the state. And I think those were big differences that we saw from the beginning, was having that clinical aspect and also those meetings from the beginning.
Cool. Terry?
Both between the home health care as well as some nursing groups, we in the planning stages have been concerned about that, but I agree both with Amy and Lydia that the strategy of inviting them to the table and utilizing their expertise in the development and the growth of the program is really, you're encompassing them into an aspect. It may not be the operation side, but it is definitely an aspect, is the clinical education aspects of this. So it's early development of the relationship. We haven't had any point yet where we're feeling like we're stepping on toes just by keeping them involved from the beginning.
Good lesson. Other questions from the audience? Or questions among the three of you? Okay, well, hearing none, and we're well over the hour, I am so pleased to have had the chance to talk with you, Terry, Lydia, and Amy. Thank you very much for joining us and sharing your experiences. I hope to be working with you to a great extent in the future. So again, thank you all. Thank you, Gary, for carrying off another show successfully. And thanks to NSEMSO, NOSOR, CLEAR, and Mayo for their support of this continuing program. We expect to be back to you in April with a program on the third Monday of the month at exactly 3 p.m. Eastern Time. We'll see you then. Thanks.
Thank you, Kevin and Gary. I really appreciate it. And thank you, Amy and Lydia, too. I've learned a lot. Bye-bye.
Thank you. Look forward to speaking to you soon.
Yeah, same here.